To continue the presentation, now I would like to request Carolyn to present her topic on social determinants of diabetic retinopathy severity and vision loss, a large, diverse hospital-based cohort in San Francisco, California. And Carolyn is a research data analyst working at Proctor Foundation, University of California. Thank you.
All right. Namaste, and thank you so much for the opportunity to present this research project, Social Determinants of Diabetic Retinopathy, or DR, Severity and Vision Loss. Second title slide, sorry. Just a brief agenda of the talk. First, we'll just touch on DR and social determinants of health, a brief overview, go over some methods and key findings, and then finally wrap up with a discussion on the challenges and opportunities. So the purpose of this research really was to quantify how the severity of DR at initial diagnosis varies by social determinants of health at a public safety net hospital in San Francisco, California. So as we go through this, I really want you to think about how can potentially existing health data be used to measure health disparities, and what are some potential challenges, research challenges that might come with this. So as previous presenters have touched on, DR is really a growing and large problem, not just in the US, but really worldwide. By 2045, they're projected to be over 160 million people to have DR, largely due to the rising diabetes rates. And this is really a problem because if DR is left untreated, it can cause vision loss and blindness. The good thing is up to 95% of these severe outcomes can be prevented with early detection and timely treatment, but what's really preventing this from happening? Previous studies have found that health disparities exist in DR outcomes by socioeconomic status, and other factors such as poor health insurance and housing insecurity can contribute to decreased adherence to diabetic eye exams and increased visual impairment risk. So really a lot under the surface contributing to that prevention not happening. So for this cross-sectional study, we extracted patients' electronic medical records from their first DR diagnosis from a hospital in San Francisco, caring exclusively for underserved patients in the city and region. And our exposures that we looked at included social determinants of health, as well as some clinical predictors. So things like insurance type, housing status, presence of comorbidities. And we also linked and looked at a community level predictor using the social vulnerability index at the zip code, so an area level measure. And then our outcomes included DR severity, which was measured using ICD codes. We classified stage of DR at the first presentation, so non-proliferative versus proliferative, or the most severe, and also visual acuity using the Logmar scale in the best seeing eye. So jumping right into the results, there were around 2,000 patients with complete DR data, and of these, nearly 300 had a first DR diagnosis that was proliferative, which is that most advanced stage that really needs urgent treatment. And nearly a quarter had some level of visual impairment, which was defined as the Logmar greater or equal to 0.3. And from some of our predictors side, nearly 21% faced housing or economic circumstances problems, and 42% were insured through Medicaid, which is a public insurance program providing health coverage to low-income individuals in the United States. And then nearly 80% had hypertension as well. So what predicts severe DR at that first diagnosis? In a fully adjusted model, patients with housing and economic insecurity saw a 35% increased risk of having an initial diagnosis of that proliferative severe DR compared to those without stated housing or economic insecurity. And why might this be? Patients who have difficulty with paying their rent or bills may be less likely to have a usual source of medical care and might be more likely to postpone needed treatment or screening. And then what predicts worse vision? So in an adjusted model, insurance status remained a significant predictor of visual acuity at that initial presentation. So individuals with Medicaid as well as Medicare, which is a public insurance for older individuals in the US, experienced worse vision, had a higher mean logMAR score than those with employer-based insurance types. And why could this be? This could also reflect access to care gaps, potentially longer wait times, or barriers to early eye exams. So what were some research challenges for this type of research that we found, and are there some solutions to these challenges that could potentially be applied beyond just this project to similar types of research? So first, there are some challenges with defining the exposures, with exposure misclassification being a potential concern. So these social determinants of health can potentially change over time, although they are relatively stable, meaning they don't change like that quickly, but we still don't want to potentially misclassify our main exposures at the time of their diagnosis with DR. So to help remedy this issue, we excluded patients who had more than 5 years between a clinic visit and their DR diagnosis date. Another issue that we encountered was some missingness in these variables from the EHR. So some variables like education level and food insecurity were close to or over like 90% missing. So we decided to link our data set to that external index I mentioned earlier using the location attributes from the patient and choosing the social vulnerability index, which contains, it combines a bunch of factors like lack of vehicle access, crowded housing, some factors that were missing in our data. There are also some outcome challenges, including things like there's a handful of patients whose DR codes were not able to be categorized by their DR severity. So we performed a chart review for this limited subset of patients and found that sometimes this DR code was just used to create a place in the chart that the doctor could write and didn't necessarily reflect the patient's status. So just really important to correctly characterize our outcome. Late on the click there, sorry. And then we also really wanted to make sure that we're defining that prevalent, that incident DR, and a way to make sure that this was to only include DR cases that had a previous diabetes diagnosis in the system, excluding patients where they just had the diabetes and DR at the same time because they might have just come from a different system and it wasn't truly an incident case. And then finally, a final challenge on the visual acuity outcome side was just messy EHR data. Because it's not originally collected for research, record keeping isn't always consistent. And so just careful spot checking and data cleaning was crucial to make sure the data was suitable for the analysis. And just some final takeaways back to that initial question, how can existing health systems infrastructure be leveraged to quantify health disparities? Just to summarize, one, this is a really increasingly important research realm with the growing worldwide burden of DR. And to achieve equity, we really need to know which modifiable characteristics and factors are most important to target. Existing data collection and health systems infrastructure can be leveraged for more inexpensive research with a high impact. And then just to keep in mind that these important challenges exist, but they can be remedied through careful study design, linking to external data sets, and quality control measures to increase data quality. Thank you very much, and thanks to my mentors for all their support and expertise.
Thank you, Carolyn, for the very important and great presentation. So a short quick question. So, what do you think about the importance of taking a broader social determinants in planning and analyzing rather than just taking few social determinants?
Yeah, thank you. That's a great question. I think, looking at factors that have been assessed a lot in the past, like age and gender, race, ethnicity, are also really important. It's important to disaggregate by those factors as well. But when these more detailed factors, like say housing insecurity or insurance type, are available, I think it's important to try and include those in these types of research as well for a couple of reasons. One, it can provide a broader perspective going beyond those more individual level characteristics to kind of look at the broader social and environmental influences on health. And two, this can really help to design even more context-specific solutions and tailored interventions for patients to try and target patients who might, be missing screenings or not coming in and engaging with the healthcare system. So, yeah, thank you.